Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this video, we'll be talking about RAAS and ADH secretion, and these are both going to be important players that help us regulate volume, status, and water balance. They're also going to be key building blocks for when we talk about more complex topics like differentiating causes of hyponatremia or syndrome of inappropriate ADH secretion later on. So diving right in, let's first talk about the Renin-Angiotensin-Aldosterone System, your RAAS system. So the function of the RAAS system, why it's important, is that we want to maintain blood pressure through our RAAS system. That's the main job of the RAAS, is to maintain blood pressure. And we do so by regulating our renal perfusion. If our kidneys are getting enough blood, we can assume that there's enough blood pressure throughout the body. So things that are going to activate the RAAS system is when we don't have enough blood pressure. When we don't have enough blood pressure, the kidneys sense this through decreased sodium delivery, primarily to our macula densa cells. Our macula densa cells are part of the juxtaglomerular apparatus, and our macula densa cells are sensing the amount of salt that's being delivered to them, and if it's not enough, that is going to turn on the RAAS system. Similarly, some increase in sympathetic tone can also turn on the RAAS system, so part of that fight or flight response to maintain blood pressure there. And once our RAAS is activated, our juxtaglomerular cells are first going to start by secreting renin. And renin is going to be our first enzyme in the RAAS pathway. So renin acts right here, and renin is going to convert angiotensinogen. Angiotensinogen is made by the liver in its inactive form, but renin, when it's released, converts angiotensinogen into angiotensin 1 and moves us through this pathway. So we've converted angiotensinogen to angiotensin 1. Then we have our second enzyme in this pathway, ACE, or angiotensin converting enzyme. ACE is an enzyme that lives in the lungs, so it just kind of hangs out in the lungs, but once it's fed angiotensin 1, it is going to convert angiotensin 1 into angiotensin 2. And then angiotensin 2 is going to be kind of our active component here that goes around to all these different organs and exerts the end organ effects. So some of the end organ effects here are in the vascular smooth muscle. So our vascular smooth muscle is going to vasoconstrict, and vasoconstriction in our vascular smooth muscle is going to be adding more pressure to that circuit and allowing us to maintain our blood pressure, right? Because we've constricted, so we're adding more systemic vascular resistance, which is going to help us increase blood pressure like our RAAS system wants to do. Similarly, when we go to the posterior pituitary, angiotensin 2 is going to tell our posterior pituitary to release vasopressin. Vasopressin, like we'll talk about in a little bit, is going to be responsible for pulling more water out of the urine and into the bloodstream. When we pull more water into the bloodstream, we're actually increasing the volume of our blood, and that is going to increase blood pressure as well. Next, angiotensin 2 is going to go to the adrenal cortex and stimulate aldosterone release. In addition to its own effects on the vasculature, aldosterone is also going to act directly on our kidney, and it is what is going to encourage our kidney to increase sodium reabsorption and increase potassium secretion. So when we pull more sodium into our body, there's kind of two functions here. Number one, we have more solute floating in our blood, so our blood is going to be better able to hang on to that water and not have it seep out of our circulation into other tissues. And then additionally, some of that water is also going to be reabsorbed with that sodium, so we are going to be increasing volume and subsequently blood pressure that way as well. And this is going to lead us to one of our key lab findings that can help us distinguish whether the RAAS system is on or off, and that's going to be the urine sodium. So like I just told you, one of the functions of angiotensin 2 and aldosterone is to go to the kidney and increase our sodium reabsorption. So what that means, when our RAAS system is on, we are going to have increased reabsorption of sodium from the urine back into the bloodstream, so we're pulling sodium out of the urine, and that's the reason that we're going to have decreased urine sodium when our RAAS system is on. So this decreased urine sodium, or urine sodium less than 30, is going to be a common lab value that they will kind of use as a proxy to see if you can tell if the RAAS system is on or off. So that's what turns our RAAS system on. But what turns our RAAS system off? Well, we talked about how the job of the RAAS system is to maintain your blood pressure. So when we start having too much volume or a high amount of volume, that's going to stimulate the release of ANP and BNP, atrial natriuretic peptide and brain natriuretic peptide from the atria and ventricles, and these are going to shut RAAS off. That makes sense, right? If we have increased volume, we no longer need to worry about our blood pressure, so we can turn our RAAS off. The exact mechanism by which ANP and BNP shut off our RAAS system is probably too in-depth for them to ask you about on step 1, But the general mechanism is that it'll cause an increase in the release of cyclic GMP, which is going to relax our vascular smooth muscle, increase the GFR, and then decrease renin release. So that's the RAAS system. But now let's talk about another system that's going to be important for volume control, and that is vasopressin or antidiuretic hormone. So vasopressin or antidiuretic hormone is synthesized in the hypothalamus, but it's stored in the posterior pituitary. And there's a lot of complex mechanisms that are going to regulate the release of vasopressin and antidiuretic hormone. A lot of complex feedback goes into the hypothalamus about regulating thirst, regulating water balance, but one of the factors that influences the release of vasopressin is actually the RAAS system itself. So as we talked about earlier, this angiotensin 2 can go to our posterior pituitary and increase antidiuretic hormone release. Antidiuretic hormone is then going to travel to our collecting duct over here in our nephron, and it is going to insert more aquaporins into this collecting duct and sometimes into the distal convoluted tubule as well, but primarily in the collecting duct. And in the collecting duct, inserting these aquaporins is going to allow us to reabsorb more water from the urine. So we're pulling this water out of the urine. That is going to have two effects. Number one, we have more water in our circulation, so we are going to add more water, add more volume to our blood. Additionally, because we have pulled water out of that urine, we are going to increase the urine concentration. And this is going to lead to a key lab value that is going to be important for you understanding whether ADH is in circulation or not, and that is the urine osmolality. So I like to think of the urine osmolality as kind of a proxy for concentration. Higher urine osmolality means more concentrated urine. And our urine osmolality is going to kind of increase as ADH increases, because if we have more antidiuretic hormone pulling more water out of our urine is going to be more concentrated, so those are going to have kind of a direct relationship there. Now, I know that was a lot of information. Let's quickly recap what we've talked about in this video so far. So first, we talked about our RAAS system. Our RAAS system is trying to maintain blood pressure. It's going to get turned on. We have anything that is lowering our blood pressure and not giving us enough sodium delivery to those macula densa cells. When it is turned on, the RAAS system is going to cause vasoconstriction, increase antidiuretic hormone release, increase release of aldosterone, and increase of sodium reabsorption and potassium wasting, which is going to lead to one of the key lab values that you should be aware of with the RAAS system, which is a decrease in urine sodium, because we're reabsorbing the sodium back into our bloodstream. And that's going to be one of the key ways you can tell if the RAAS system is on or off in the absence of confounding factors like diuretics or whatnot. The second system we talked about was vasopressin or antidiuretic hormone. And the release of vasopressin is regulated by a lot of factors, but it can be released when the RAAS system is on. And vasopressin exerts its effects by binding to the V2 receptors in our collecting duct. Those are going to be increasing the aquaporins in the collecting duct and sometimes the distal convoluted tubule as well. Vasopressin is also going to bind to the V1 receptors in our vasculature and exert its own effects there, that vasoconstriction. So those are kind of the two mechanisms of vasopressin. Vasopressin is going to increase water reabsorption, and in so doing, increase our urine concentration because we're pulling water out of our urine. That is going to cause an increase in the urine osmolality, and that is going to be a key lab value to be aware of when we're talking about is vasopressin present or not. So that's a lot of information, but how would they ask you about this in a step 1 question? Well, something they might ask you is something like a patient presents with jaundice, ascites, and bleeding esophageal varices, and then they might show you a table like this and ask you what will their urine osmolality, their urine sodium, and their volume status be. Well, I told you that we have a patient with jaundice, ascites, and bleeding esophageal varices. That sounds like a patient in liver failure. And when you're in liver failure, our liver is responsible for a bunch of things in the body, but one of the things that it does is it synthesizes albumin. So when your liver is failing, you're not making as much albumin. And albumin is a protein that, amongst other things, is responsible for holding a bunch of that water in your vasculature and making sure it doesn't seep out into tissues. So when you have decreased albumin, that's going to mean that you're not able to hold as much water in your vasculature, and it is going to seep out into tissues. That's what's going to lead to ascites if it seeps into your belly, edema if it seeps into your legs or extremities, hydrothorax if it seeps around your lungs. And that is going to make you hypervolemic because you have all this extra water on your body, right? The edema, the ascites, you clearly have a ton of extra fluid in your body. But because you don't have a lot of albumin, that fluid is not actually in your vasculature. It's just kind of hanging out in other parts of your body. And that is why, from an intravascular standpoint, you are actually hypovolemic. And that is why, even though you have this extra volume burden on the rest of your body, your RAAS system is actually going to be on when you have liver failure and cirrhosis. So your RAAS system is on, and if I tell you that your RAAS system is on, what is going on with the urine sodium? Well, like we talked about earlier, whenever our RAAS system is going to be on, we're going to have decreased urine sodium, so a urine sodium that would be less than 30. And then similarly, because you don't have enough volume, you don't have enough fluid being held inside your vasculature, your ADH system is also going to be on. So your ADH system is on, which means that your urine osmolality is going to be high. And your urine osmolality is high because you're pulling all of that water out of your urine, pulling it back into the vasculature, and in so doing, you are making more concentrated urine. More concentrated urine means higher urine osmolality. Now, one quick note, I do want to emphasize that in this scenario, the ADH is paralleling what our RAAS system is doing. RAAS is activated and ADH is also on. It's not always the same though. Remember, I talked about that complex mechanism of regulation of thirst and water balance. There's more than just the RAAS that's feeding into the hypothalamus to determine if ADH actually gets released or not. So just a good thing to keep in mind that they're paralleling each other in this example, but that's not always the case. So a good thing to look out for and be aware of. Now, that's all I have for you on RAAS and ADH. I hope this video was helpful, and I'll see you next time.